for Newham. And today we've got 3 speakers who are going to give us some scenarios and run through some case studies with us. And we'll then be taking questions and talking through any scenarios that you might want to run by us. We'll run through some ground rules in a minute, but just to let you know, we will be recording. The recording has started. And if you don't wish to be on camera, please switch your cameras off. If you're not speaking, if you could turn your microphones off for us, and that stops all the rustling.
I can't hear anything. Oh no, I can't hear anything. I need ears. Oh no.
So raising your hand up if you want to speak during the Q&A session, or putting a message in the chat. The chat is being monitored, and we'll be picking some stuff out of that. This session will be available on catch up if you've got colleagues that wanted to join but couldn't because they've been stuck clinically. And you can join us all on Twitter talking about this. It's hashtag share the message, Ask About Asthma, share the message this year. And yeah, and the main messages this year are, as always, for Ask About Asthmas: making sure you take your medicines and use a spacer, making sure you get an asthma review, and making sure you have an asthma plan. So things are slowing down with the admissions. So the 3 speakers we have today are Alison Somerville from the Hillingdon Hospitals. We have Natasha Brennan from Whittington Community, and we have Sarah Latham from King's College Hospital. And we are going to start with Alison.
Okay, thank you, Emily. I'm going to share my screen now, hopefully, if you just bear with me for one moment.
It's nice to see so many people that are joining us as well. There's an amazing amount of people joining us.
Okay.
Whilst we're waiting, if you have any scenarios or questions, as I say, please don't hesitate to pop them in the chat box or to raise your hand at the end of the sessions once all 3 have spoken.
I'm hoping, Emily, can you see that? So that
I can indeed, Alison. Yeah.
Okay, thank you very much. So first of all, thank you for inviting me to present a case study today. I'm going to share a scenario of a little boy that I saw quite recently, actually, in one of our role modelling clinics. We have been in the fortunate position in Hillingdon to be running a project over the last 18 months, working really closely with colleagues in primary care, practice nurses and pharmacists, where we have jointly run half-a-day clinics over 6 consecutive weeks in upskilling and supporting practice nurses and pharmacists on a one-to-one learning upskilling clinic of reviewing children from their practice. So this little boy is a young lad who we saw, and he is 8 years old, a little boy called Jamal, who we saw recently in clinic, as I say. He was seen in the primary care practice. Myself and the practice nurse had invited him for a formal structured asthma review. And going through the history, he'd been admitted to the local hospital with a severe asthma attack 3 years previously. He'd been a known asthmatic since 4 years of age and has coexistent atopic conditions, including allergic rhinitis. He'd had eczema since he was a young infant, which has improved with age. Still some eczema there, and it's not gone completely, but it certainly has got better as he's got older. One of the beauties and opportunities of working in primary care, which we don't have this in secondary care, is that you have the wonderful systems of being able to look and see exactly what children have been prescribed during the last 12 months. And prior to Jamal coming in with his mum and his elder sister, we were able to identify that he'd had 8 salbutamol inhalers that had been issued on prescription during the last 12 months. I think we'd all be aware that obviously that's quite a large amount, and we're aiming for at least less than 6 annually. Looking at that in a little bit more detail, together with the practice nurse, he'd actually been issued 2 salbutamol inhalers at every prescription. Whether or not he'd actually needed them was another matter. He had a Clenil inhaler as his preventative medication. And talking through and going through the structured asthma review with him and his mother, he was having symptoms of coughing and shortness of breath at least twice a week, disturbance at night with nocturnal coughing, and that was happening at least weekly, and any exercise was causing him to get short of breath. So when he was running around in the playground or running upstairs at home, he became wheezy and was coughing and needed some of his salbutamol. So in terms of what he was doing at school, he was using the salbutamol intermittently, not as frequently as he was needing it at home. But just actually inquiring and talking through things with mum and his elder sister, he'd actually missed 5 days off school during the last 12 months. And I've already mentioned the fact that he was needing his blue inhaler 1 to 2 times a week at home. So looking over his history, and also in terms of the consultations that had happened within the practice during certainly the last year, it became apparent actually when reviewing everything, he'd had no asthma review at all in the practice since his review with the nurse specialist post his admission 3 years ago. And I think this is something that we've found commonly, because it's actually quite tricky to undertake a paediatric asthma review if you don't have the knowledge base and skills, and people are often a little bit concerned. But certainly through the role modelling project that we've been running, I think the practice nurses have gained an enormous amount of confidence and competence in carrying out these really extensively and very well. So here we have this little boy who, as I say, is 8 years old with asthma, previous severe attack, but still needing his blue inhaler actually quite frequently. So what things would you be worried about? The things that jumped out for me were, in my opinion, hopefully many of you will be feeling quite similarly, he's actually got quite a high prescription rate of salbutamol, needing 8 inhalers in the last 12 months. That's the equivalent of 1,600 puffs of salbutamol. He's had no asthma review in the last year, despite the fact that he was hospitalised with a severe exacerbation, and school absence is always a concern. He's missed 5 days during this last 12 months. And do we know what his adherence is truly like? I'm not sure. Do the issues of medication of his inhaled steroid equal the dosages that are prescribed? And again, in the primary care setting, it's wonderful because you've got all of that information, whereas certainly in secondary care, we very often have to contact the GP practice and ask for prescription update. So that's something that you can often work out mathematically. And what actually is his inhaler technique like? What would you do? For me, I think his asthma is suboptimally controlled. He's needing to use salbutamol too frequently, missing days off school, and he's got symptoms on exertion and also nocturnally. So do we increase the dose of Clenil or change his prophylaxis? So we sat and thought about that with Jamal and his mother and his elder sister. What did we actually do? His inhaler technique was assessed, and I think one of the questions that certainly in clinic, whenever we're seeing children, one of the questions we should be asking is, show me how you're using your inhaler. He had an absolutely superb technique with tidal breathing. So he's 8 years old. He was taking beautiful slow breaths in and out. But on demonstrating what he was actually doing there in the surgery, he was tidal breathing with a metered dose inhaler. So straight away we have, one of the things that's actually going wrong here. This little boy, yep, he's got a great technique. He's on an appropriate dose of inhaled steroid for his age, but actually most of the medication is probably not even reaching his small airways. So we took some time in terms of educating about adherence, the importance of twice daily prophylaxis. Certainly some of the questioning led us to other answers in terms of, well, maybe he misses it once or twice a week. I think we all know that if you're missing it once or twice a week, it's probably a little bit more. So supervising him taking his medication rather than leaving him to take it on his own, which very often happens from my experience with a lot of children. He was given a prescription for an age-appropriate spacer, and we were able to teach him how to use that effectively within the consultation, and also talk about the care of the spacer. He had an asthma action plan provided, and we certainly use the Asthma UK plans in the Borough of Hillingdon because they're easy to complete, and we're very fortunate that we've got them all set up electronically, both in primary and secondary care. We issued him with a peak flow meter as a way of measuring and monitoring his asthma, and the values were incorporated into his peak asthma action plan. Also contacted the school to assess his exercise tolerance there and how frequently he was truly needing the salbutamol inhaler. Certainly one of the questions when he showed me that amazing technique with his metered dose inhaler, one of the questions that I asked him was, what do you do at school? How do you take your inhaler at school? I have a spacer that I use at school. With a mask or without a mask? Oh no, I use the one without the mask. And certainly that's one of the things I think that we have been very fortunate about in the Borough of Hillingdon is that we've got a very proactive schools asthma programme, and there are no children who have asthma who do not have additional needs using spacers with masks over the age of 4, because the schools will turn the children away or turn the parents away and ask them to go back to the GP and get an age appropriate spacer. Very fortunate that welfare assistants monitor this and are actively involved in actually supporting children and helping them learn the correct technique when you're using a spacer or mouthpiece. So that was quite encouraging. I think one of the other things that is worthwhile mentioning and considering is that when he'd had his review 3 years ago with the nurse, Mum's message to me and the practice nurse was, well, no, he'd been told he didn't need to use that anymore because he was too old. And actually what she was referring to was the spacer and mask. So absolutely the right information, but when it had been then interpreted, they'd assumed he didn't need to use the spacer at all and could just use the inhaler into the mouth, which I think we all know, as Emily alluded to just earlier on, using a spacer to take the inhaler is so very important. So he went away. We didn't increase his inhaled steroids. We got him onto an appropriate spacer with a good technique, and then he came back to see us in a month's time. So I don't know whether anybody has any questions straight away that they would like to ask or discuss, challenge on any of the presentation of this case study. Natasha and Sarah, you might have something that you wanted to add.
I definitely say that having access to the prescription surveillance in general practice is really, really helpful. I found it to really help a lot of my patient consultations as well. And unfortunately, we don't have it throughout, but yeah, I agree. It's really, really great.
I concur. I use prescription uptake a lot to try and figure out what's going on for those more complex children on my cases.
I think the other thing.
Sorry, Alison.
Sorry, Sarah.
Sorry, it's difficult, isn't it? Because sometimes when we check prescription uptake, we can see that they may have picked up a good amount of the preventer. It doesn't actually mean that they're taking it. It's a good guide, but they could be stockpiling. So it's one of the very useful ways, and especially as you were saying, Alison, to see how much salbutamol is being used. Obviously, it's very useful. It's not foolproof, but it's very good.
Yeah, I would agree. And I think certainly the work that we've done through the role modelling clinic and certainly with our schools programme, you get down to the nitty gritty. And I don't think I can sell integrated working as much as possible or enough. It really is, it tells you and you learn so much about it, and being able to also, when you're seeing children and families, asking those questions that are so important in terms of, well, how many times a week do you actually forget to take your inhaler? You know, you're almost giving them permission, not that it's okay, but permission to tell you how many times they truly aren't using it, because none of us are perfect. I can see a question that's just come up in the chat there about masks. So our aim is to move children over to using a spacer with mouthpiece by the absolute age of 4. We normally start teaching them to do that around about 3 years of age. But there are some children, of course, who have additional needs, who may not, because of their sensory issues, ever be able to use a spacer and a mouthpiece. But there are many spacer devices around that have got masks, and you can prescribe the ones with an age appropriate mask for that individual child.
And I do like that, Alison, the fact that we've now got a range of masks for a range of different ages and size. So although, you know, our special needs children are not just stuck between the old aged COPD mask that doesn't fit anyone and a yellow face mask, there are actually some really appropriate additional supplies out there that we can be using. Caroline, did you have a question? You've got your hand
Yeah,
up.
just want to ask, what age should this child be prescribed a spacer?
So all children should be using spacers, and I would personally advocate that you never ever grow out of a spacer. It is the best way of delivering the medication into the small airways. Certainly in terms of teaching in schools, the teachers learn so much about their own asthma and then take that on board. And in fact, we had a meeting just last week with some GP trainees, and one of the GPs came to me afterwards and said, my asthma improved when I got married, because my wife nags me to take my preventative inhaler. Mums are very good at that as well. But secondly, I get what you're saying. I need to go and get a spacer just to optimize his asthma control.
Okay,
Alison,
thank you.
I wonder if maybe one of the barriers is that with the GP documentation platform EMIS, sometimes, coming from a personal perspective, when I've tried to prescribe something, it says the word, but it doesn't show you an image. So I think sometimes they think any child spacer with mask, they don't realise it's actually for the child with additional needs. And I've definitely found that to be a recurring issue, that because they can't see it, they think it's the right spacer device.
Yeah, I think one of the things that we've tried to do in Northwest London is we pulled together some Northwest London prescribing guidelines for asthma in children to help that consistency. And I completely agree with you. When you're looking on EMIS, you often have to go down to find the spacer which is most appropriate. It's not always at the top, and that ends
No.
up being very confusing. Completely agree. And I think those North West London guidelines have helped that, because we've moved over to one particular spacer that we, you know, as a consensus made a decision that we would try to use that one for consistency.
Absolutely. We've had some questions in the chat, but I know Gina Isles had her hand up and raised. Gina?
Oh, hello. I'm quite new to asthma, being a nurse as an asthma nurse. Can't get my words out. But we're going to be setting up a clinics actually in school, because we're trying to sort of like improve access to services, and we wondered whether trying to do it in schools would be a better system. But what I'm interested in is, so we'll be doing annual reviews, but does I wondered how, in terms of GP services, how do annual reviews first get triggered? Is it that they've been prescribed as an inhaler? Is it that they have to be diagnosed with asthma? I just wondered how the system works in terms of eventually then being invited for review. That's a bit I don't understand yet.
As far as I'm aware, Gina, they need to have a diagnosis of asthma. So somebody needs to have been brave enough to have put that diagnosis down and then put them on the asthma register for the GP practice. Okay. It doesn't tend to happen with the viral wheezers.
Okay. So there may be children that have got inhalers because they had them when they were much younger or something like that, but actually have never been diagnosed. But those ones won't be particularly picked up.
No, they shouldn't be picked up unless it was a diagnosis of asthma.
Okay, so we just assume that they
were probably a viral wheezer that never quite lost the salbutamol hold. They all cling on deeply. Okay. I think we're going to move on now to the lovely Natasha, who is our paediatric nurse practitioner from Whittington. For those of you that have put questions up in the chat, we're going to chat about those. We're going to bring those to the end of the chat when all three presenters have presented. So don't panic if you see a question that you also wanted to ask in that chat. Just put a like beside it so that we can see that it's a popular question for us. Natasha.
Thank you. Hi everyone, thank you so much for joining us today. I work within a practice called Paediatric Primary Care, and we're based in the community, and one of the services that we offer is the 48-hour telephone triage service. And today I'm going to talk to you about the importance of effective working between primary and secondary care, and how it provides a positive impact for the patient journey. So this is a 12-year-old female patient called Shannon, and she attended her local GP, her local A&E department for an acute exacerbation of asthma. She was discharged home with 3 days of oral prednisolone, a new age-appropriate spacer, and an updated asthma care plan. At the point where we were notified of her discharge, we contacted her within 48 hours via telephone. And the aim of that assessment was to assess her recovery, her progression, and her control. Now, we know that, especially our team, prior to us launching this service, a lot of patients weren't being contacted within this time frame, and that did, unfortunately, for some patients lead to reattendance to A&E. So at the point of 48 hours, we assessed her recovery, her progression, and her control, to which we identified that some of her symptoms were still present. She hadn't deteriorated, but she was having some issues with her exertion, an increased need of salbutamol, specifically at night. When we asked her to complete her peak flow, it was slightly below her predicted average, but it wasn't anything too alarming. So what would we be worried about at this point? So we're on the phone to the parent and the patient, and we've assessed that she's not fully better. There's a few symptoms still present. So what would some of the things we'd be concerned about? So is she deteriorating? Could this result in a readmission? Is her inhaler technique correct? and what is her adherence truly like. So at that point, I was on the phone to the mum. I asked if she was happy to do a virtual consultation. So we switched over to a virtual platform. I checked her inhaler technique. It was fine. And she advised that she did complete her 3 days of oral prednisolone. So what was done at that point? I think it's really important at this point to highlight the importance of communication between ourselves and the GP practice. So one of the things, one of the agreements with the 48-hour review was that the 34 practices within Islington had a shared agreement that if at the point of assessment the patient needed potentially a chest review or an extension of their asthma medication, they agreed that that patient could be booked in for the same day appointment. So I ensured a bit some safety netting. There were no there was the absence of red flags, which was great, but I said to mum, look, I think that Shannon does need a chest review and potentially her oral prednisolone might need to be extended slightly. So made the call to the local GP, had her booked in that same day, and they extended her prednisolone, which was brilliant, and also gave her some advice about when to use salbutamol for the next couple of days. So I think, you know, that brilliant working between the secondary and primary care prevented her from reattending A&E because it could have resulted in a readmission. Following the call, we booked her in for a review within 6 weeks' time, just to ensure her management and control was on track. And actually, when accessing her GP notes, we found out that this patient hadn't had a formal asthma review in over 3 years. And as we know, following recommendations from the NRAD, it suggests that asthma reviews are a great opportunity to assess management and control and to optimise management accordingly. So I just quickly want to go back to the importance here of working relationship. So why is a 48-hour review vitally important? Well, one, it first establishes if the attack is resolving and it identifies any absence of red flags. And secondly, to reduce the further risk with an aim to get control. Now, with our interception at 48 hours, we identified that this patient was not progressing in the way that we would have liked. And we were able to get that patient seen by the GP the same day, who was able to provide the care that she needed to prevent a readmission. Good working relationships with hospitals and GPs are essential to ensure a streamlined service for patients travelling between primary and secondary care. Paediatric primary care, myself and my team have built good relationships with all of the 34 practices within Islington. If a patient requires a same-day appointment with the GP, there's a general understanding that that child or that patient has triggered and needs a review that same day. So I just want you guys to have a look here. This is our triaging score that we use. It's very, very easy to navigate, red, amber and green. If a patient is green, they're good to go, they're recovering as we would have liked. We will just book them in for a review in 4 to 6 weeks' time if they're not under the care of a consultant. If they score amber, which Shannon scored, they're not, you know, there's not an immediate concern where they need to go back to A&E, but potentially we need to assess whether this child needs an extension of their acute medication or some support, maybe a 24-hour follow-up on the phone the next day. If the child scores red, straight back to A&E. And what we identified from our data, going on to the last slide, is that the scoring system is safe. It identifies patients correctly. There's been no adverse outcomes, and actually receiving this triage means that patients are 2.5 times less likely to reattend and 3.8 times less likely to be readmitted. So it's a really amazing tool, but I'd just like to highlight that this wouldn't work if the communications between the hospital, myself and the GPs wasn't effective. So I really like home in on the communication is really, really important.
Natasha, can I just ask you a question on your tool, because it looks great and it looks really effective and practical to use. Once you've completed your tool, because we do 48-hour reviews on all of our children, telephone consultation reviews, Does
Yeah.
the score automatically get through to the primary care practice in some
Yes.
way? Yeah. Okay.
Sorry,
Good.
sorry, I forgot to say that. So we use the platform that the GPs use. We're very, very lucky in that the Islington CCG allowed us to work directly on GP platforms. So we built this template and embedded it into their system. So when we are actually on the phone to the patient, during the talk, during the consultation, as soon as we press save, it's active for all of the GPs to see. So when I call them and say, I've just triaged Shannon, they can see exactly what I've done.
Great.
Amazing. Can I just ask that those of you who have joined us and have missed the ground rules, if you can all go on to silent and turn your microphones off for us, because we can hear somebody's phone ringing at the moment. So that would be really helpful. Thank you. Amazing work, Natasha. I love hearing about your system, and it's really amazing that you're getting such fantastic results. But I think, you know, the communication between yourselves, the hospital, and the GPs, and being able to get those appointments for the children on a really clear scale, and them understanding why that appointment is needed is so key. And I think for a lot of the practices that I speak to, they don't really understand the necessity of the 48 hours, and they just don't have the appointments at the right time for those patients.
Yes. And I think what we found is that obviously we're able to capture a large proportion of these children, but it's just a few that need that chest assessment or that extension of the, you know, acute medication. But I think we've actually reduced their workload by quite a significant amount, because we're picking up all of the patients and providing a telephone triage. So they actually see it as, oh, okay, you know, we've actually got a reduced workload because we're not triaging every single patient that's being discharged, you know, the nurses are. So they have been really, really supportive, and we haven't really had too many problems, which is great.
Amazing. Does anyone want to raise their hand and ask Natasha a question about her slides and about what she's been presenting? For those of you that have raised issues in the chat, we're gonna bring that on towards the end of Sarah's presentation. Okay. So thank you so much, Natasha. I'm sure once people have sort of absorbed that, we'll have a few more questions towards the end of that. Certainly, we've been looking at using your work as a little bit of an inspiration when our families are ringing in looking for advice over the phone. And certainly we sort of keep your triage tool in mind, and it's really, really useful for that. Where we struggle, of course, is getting in with the GPs. So with our thanks to Natasha, we're now going to move on to Sarah. Sarah Latham is one of the senior paediatric respiratory nurse specialists at King's.
Thank you very much. So I wonder how many times the sentence, "Can everyone see my slides?" has been said, but can everyone see my slides?
Yes, we can.
Fantastic, thank you very much. So this is the final case study for this bit of the webinar, and we're moving up the age group. I'm going to talk about a young person who's 14 called Corinne, who was referred to my clinic a while ago. He's highly atopic with asthma and eczema. His allergic rhinitis is perennial, so he's allergic not just to tree and grass pollen, but to house dust mite. He's had 3 asthma attacks in the previous 12 months, comprising 2 out-of-hours presentations and 1 hospitalization for a severe attack, which merited intravenous bronchodilators. He's also been sent home at least once from school after football, and he's seen in October. So on auscultation, there was widespread wheeze, and you could see just by looking at him, his chest was overinflated, but there were no overt signs of respiratory distress, no accessory muscle use. We did his lung function, and it was reduced. His FEV1 was 60%, with a highly significant bronchodilator response of 48%. And as you know, if the bronchodilator response is 12% or more, that's significant. We also did his FeNO. For those who may not be familiar with it, it stands for fractional exhaled nitric oxide. So nitric oxide is produced in the lungs where there is inflammation, and the FeNO test provides an indication of the presence of eosinophilic inflammation, i.e. that found with someone like Corinne who's got really allergic asthma. It can be a very useful tool. The normal for children is 35 or less, for adults it's 40 or less, and you can see Corinne's was really high at 124 parts per billion. Just as a quick aside, we do use FeNO sometimes as well for young people who attend our complex asthma clinics, so not Corinne, where we think they're not taking their treatment, i.e. most of the time. And it's slightly onerous because we ask the young person to come into our chest unit and they are observed taking their whatever they're on regularly, which often is Relvar, which is a once daily combination inhaler. And often we children who attend that clinic are on that particular preventer. So they're observed taking it, then they do their FeNO test over 5 successive days. And often it's a really useful tool because the FeNO will start off at being, 150 or something. And then by Friday, it's reduced, maybe not to normal, but, back to 50 or 60. So that's a very good tool to show the young person what regular taking of Relvar can do to their airway inflammation and hopefully symptoms as well. So to get back to Corinne, despite these objective tests which illustrate his asthma is not good, he scores his asthma control test as 23 out of 25. So this is a very good example of a young person who's got poor perception of symptoms. I'm sure you've all come across this before. It's almost like the young person gets used to having a tight chest, gets used to not managing with exercise, gets used to maybe waking up at night, and they just get on with life. So this is a really good example of denial of symptoms, which is a worry. For those who may not be familiar with the asthma control test, this is what it looks like. This is for children 12 years of age and above. There's also one for children aged 4 to 11. These are validated questionnaires, and they're really great. So the top score for this one, the 12 and above, is 25, and 19 or under represents suboptimal control. But Corinne thought he was, his asthma control was fine. So what treatment was he on? He was on fluticasone 50 micrograms, 2 puffs twice a day. He's not taking his treatment, not surprisingly. He's on PRN salbutamol. And already Alison's Jamal, who was 8, his 8 salbutamol meter dose inhalers dispensed over the previous 12 months was bad enough. But this, you might think I'm making this up, but it wasn't. It was definite. 36 salbutamol meter dose inhalers were dispensed over the previous 12 months. And again, like Alison said, we've fairly recently been able to access GP records at my hospital, which is great, just depending on where they live. But as we were discussing earlier, you can also see how many preventers have been dispensed. But it's not foolproof. It's a really good attempt to gauge compliance, isn't it? But as I said, there could still be stockpiling, at home. And the other quick point, I just remembered something, sorry, is that to make sure that families look at the dose counter of inhalers generally, because often it might say 0 and it still has stuff that squirts out. And so just make sure the parent stops using it when it says 0. You only discover that with just a quick aside. So Corinne is using the meter dose inhaler on its own for both reliever and preventer, and is on cetirizine 10 milligrams once a day. So Corinne already ticks lots of boxes for death from asthma, doesn't he? The National Report of Asthma Deaths, which we referred to before, identified several risk factors, of which excessive prescribing of salbutamol was one of the key ones, and not taking their treatment, and a previous asthma attack. So Corinne, he needs to be, in inverted commas, sorted out, or an attempt to sort him out. So with any young person, it's important, isn't it? If we can, it's difficult to get time, I know, ideally to see him on his own, to ascertain what he thinks about his asthma, what's his level of understanding of asthma and its management. From what I've told you, it doesn't look particularly great. And can he differentiate between the reliever and the preventer? And obviously he's relying far too much on his reliever. He's not taking treatment to sort out his underlying airway inflammation. The importance of discussing triggers too is key. And even in young people where you've identified the triggers, they may have a new trigger, like a cat or something. So it's always good to go through what triggers and trigger avoidance. So does he smoke? And if he does he a cannabis smoker? Does he hang out with friends who smoke? Do his parents smoke? It's important to go through that. And then we already know he's got dust mite and pollen allergy. So just have a quick chat about what his home environment's like, what's his bedroom like? Does he sleep on the bottom bunk, thus increasing his exposure to dust mite? And how was he during the summer? How bad was his hay fever? And I think one of the most important questions to ask in terms of triggers is, has there been any change in the home environment? Because often people don't volunteer stuff, do they, unless you ask? So it's quite common, isn't it, for children to be sort of tipped over the edge and have an asthma attack if they catch a cold. Plus, there's building works going on at home. So it's always good to inquire about that. Or have they suddenly bought 9 cats, anything like that. So it's good to inquire. And what about stress? We know stress is a significant trigger, isn't it, in young people? Because of his age, he might be having important exams. And what about any social problems? Is he being bullied at school? And what about his mood? And that's a lot, I know, to encompass in a consultation. But just to bear these points in mind and try and get as rounded a picture as you can, depending on how the how well you might know the young person. So Corinne obviously needs prednisolone, and I think I prescribed 5 days, a 5-day course, because he'd been so unwell for some time, and given that appalling lung function and high FeNO, it's important to optimise his hay fever treatment, because there's cetirizine 10 milligrams once a day, which I thought he was taking every day. It just was an inadequate level of treatment. So I changed to fexofenadine, which has a wider therapeutic benefit than cetirizine, 120 milligrams once a day. You can't buy it over the counter, unlike cetirizine, so it must be prescribed. And Avamys nasal spray, 27.5 mics, 2 sprays once a day. And it's always important to go through technique, isn't it, of nasal spray as well. Otherwise, it's tempting, isn't it, just to blow your nose and just sniff it up. Then you end up swallowing this. So just make sure you go through that as well. So I elected actually to go up to a combination inhaler, even though he wasn't taking his fluticasone and he was taking it with the wrong technique. But I was so worried about him, and I also wanted to steer him away from that excessive salbutamol use. So I prescribed the budesonide and formoterol combination inhaler via the turbohaler, 100/6, 2 puffs twice a day. The benefits, as you'll know, of formoterol is its onset of action is similar to that of salbutamol, so they get relief really quickly. So 2 puffs twice a day. I put him on the MART regime, which, again, for those who may not be familiar with that, it stands for Maintenance and Reliever Therapy. So it's a way of steering him away from using salbutamol. So it's 2 puffs twice a day, regularly, as a preventer. And in addition, per 24 hours, he can take an extra 12 doses of the budesonide formoterol combination inhaler, but used as a reliever. So he gets a boost of the steroid and the almost immediate effect of the reliever. We do put quite a few young people on the SMART regime or MART regime and find it's really effective. I can think of 2 young people yesterday in clinic, and they said that they really like using a combination inhaler as a reliever because of the immediate relief. And also in terms of the device, which is very important, we've spoken about a lot in the previous 2 sessions, because it's with a dry powder device, a turbohaler, you don't need a spacer. So it's portable, it's discreet. So it's not like Cream has to, pull out a spacer so everyone can see him using it. So that's another advantage of using the turbohaler. The final slide is, it's always important, isn't it, to get the person to repeat back what you've said. And I don't know about you, the number of times I've asked someone to repeat back what I've said and they've said something quite different, which is a bit depressing in terms of how effective an educator am I. But anyway, so I got Kurim to repeat back the details of his treatment. The importance of giving a written asthma plan and making sure it's up to date to back up your discussions is important, as we've discussed. And again, to reiterate Alison's and Natasha's point about school liaison is really important. So if we're really concerned about a young person or, primary school age, we always contact the school just to find out how they've been. So has he been having problems with sport? Has he been missing school? But mind you, normally we are chased, aren't we, if there's excessive school miss. But the other use of school, in inverted commas, can be in some other young people to use the DOTS, which stands for Directly Observed Therapy. So if you're concerned about a child not taking their preventer, and you've tried your best, you've tried to facilitate compliance by making it whatever, a once daily, for example, Relvar, sometimes we ask the school to supervise them taking their regular preventer, so just once a day, obviously Monday to Friday. And that's obviously, you can't do that forever, but it's quite useful to do that for a limited amount of time if the school are able to do that. So that's, so it's very important. Use of school sounds a bit funny, you know what I mean? And then follow him up in 8 weeks' time with repeat lung function. And also, I think I did do an interim lung function 2 weeks later. And sometimes it's quite helpful to do fairly intensive follow-up, isn't it, with young people that you're concerned, or any patient that you're concerned about. So maybe do telephone reviews as well as, eventual face-to-face. And this last bullet point actually is a huge area on its own, but the importance of discussing transition with young people. And it doesn't matter, does it, what caliber of asthma their day-to-day asthma is. It doesn't matter if it's mild asthma or more severe, transition still must be discussed. And I think also the career choice, I'm not very good at bringing up career choice, but I think it's incumbent, as the BTS guidelines say, for us to ask them if they've got a particular career in mind and explain what they should avoid doing, like any jobs, involving exposure to dust, fumes, spray, they should try and avoid that. And I remember once we had a young person who was 16 who was highly allergic to cats, but she was determined to be a vet. So that was a tricky one, and she was quite, firm in her choice. There was only so much that you can do, but at least it's up to us to give advice as best we can. So thank you very much for listening. That's my final slide.
Thank you so much, Sarah. So much of that resonated with so many of my teenage patients that come to see me. Especially the using of the MARC regime. I've got quite a few that are really enjoying that freedom, actually, to be able to control what's going on, especially those that were overusing salbutamol, and they've really gained control through using MARC. So it's been quite revolutionary for some of my young people.
I don't know about you, Emily, or anyone else, but I used to find, and I still do sometimes, find it quite difficult to explain to families, and it's quite difficult for them to think, what? So I'm not supposed to use salbutamol. So it's quite a big change, isn't it?
It's a massive change. And the other big change is, I can remember once being shown, when you were talking about asking things back, I hadn't seen this patient, and she came back into clinic, and I asked her to show me how she used her Symbicort, and she took a blue aero chamber and she rammed it into the end of the aero chamber, and she inhaled it beautifully with the correct technique. And I just went, okay. And she'd actually been sent home with written information as well as to how to use that device. That is a very true story. And she then proceeded to tell me that a very well-known asthma nurse, who I knew extremely well, had taught her that technique. And I was like, might we be confusing salbutamol with that use? Okay, great. So it is about, and I use that with great humour, and I do reel that one out because it is amazing how people manage to misinterpret very, very simple instructions sometimes. Thank you so much, Sarah, for that. We have had a little barrage of questions in the chat. There are lots about spaces. And Alison, I wonder if you'd go through just about the ages and the older children using face masks and why that's not such a great idea.
Yeah, of course. I mean, I think we mentioned earlier on, you never grow out of a spacer, but I would echo what Sarah has said, is that, you know, as the children become older, you've got to look at more portable devices for them that are user friendly. They can pop them in their pocket or their sports bag. You know, most adolescents are not going to want to carry a spacer around, and I think as, you know, healthcare professionals, we shouldn't be expecting them to do that either. So completely with you, Sarah, the breath-actuated devices for the older children is really important to give them that opportunity and choice. In terms of the younger ones using spacers, of course, if they're under the age of 3, you really have little choice apart from using spacers and masks. The reason for trying to move them on around about the age of 3 and ideally by 4, as I said earlier, unless they've got additional needs, is because whenever you're using a spacer and a mask, most of the medication sits on the face. And if it sits on the face, it doesn't get down to the small airways. So that's the reason for trying to get them to graduate onto a spacer with a mouthpiece, if you like. And, you know, the easiest way I personally find teaching a child how to use an inhaler is to demonstrate it. They pick it up so much quicker, it will save you time, and their technique will be much better. Now, of course, there will be some children who absolutely no way, for whatever reason, you cannot get them to use a spacer and a mouthpiece. And yes, of course, then you have to be thinking longer term with spacer and mask. But from my experience, they go on to a spacer and mask when they're little, and then actually it never gets changed. So they arrive in school or they pitch up in, you know, secondary school, and then they walk with a spacer and a mask. That shouldn't be happening. We should be aiming, you know, around about the age of 3 to 4 years of age, if they haven't got additional needs, to move them onto the spacer with the mouthpiece. Just because deposition wise, you're going to get more medication into the small airways and it will work better. So does that help? I mean, Sarah and Natasha, if you agree, disagree, chip in.
No, I think that's absolutely right, Alison. And also there are some non-static aero chambers. We haven't mentioned that, have we? But there are some non-static ones which are fantastic. You don't have to faff around washing them in warms. You can do what you want with them, basically, can't you? So they're very good. And I think
the flow view, the aero chamber flow view, and I quite like them because the little people can look at the flappy valve, and you know very straight off, especially with the little ones, whether or not they've got it.
Yeah.
Nina, you've got your hand up. Sorry, Natasha. Nina, you've got your hand up. Nina Somerville.
I just wanted to add as well, just to what Alison said with the mask, that I found it was a boy yesterday that obviously if you're using a mask and it is a steroid we're giving, the patient may possibly get lightening of the skin around the face. So it's going to cause some, you know, possibly, you know, that's going to make them feel different to other children. And it does take some time. So I think that's another important reason to switch them over to the mouthpiece quite quickly. I think I found as well.
Somebody mentioned about the children sort of that were the non-compliant in an emergency situation. Actually, I feel quite strongly that we should be advocating right from the very beginning the right technique. I think if you're clamping a face mask over somebody's face to get medicine in, it sets them up wrong. We need to be talking to them rationally and getting them to use the right technique and getting to them to use those mouthpieces. I hope that answers that.
In Whittington, we use the able spacers, which actually come with a mask that can be detached, and you can actually pop the rescue medication into the chamber. So I find it's a really good way to encourage the adolescent group. Look, you're not going to be carrying two things. Pop your blue inhaler into the chamber, put the lid on top, and it's a really good way to just keep it in your pocket, because you've not got two things. You can compact it into one. And with that specific device, you can actually remove the mask if you wanted to. So you get both with that one device.
That's our other choice of spacer. Sarah.
So just a quick question. You know, when you put the inhaler inside the able spacer, Natasha, because we don't use, obviously I know of them, but I don't actually use that. We don't use them, but it doesn't damage the, not damage, but have an effect on the inside of the spacer, does it? Obviously, you know, the inside of the spacer. That's fine, isn't it? Must be.
No.
Okay.
And they actually do a compact version called an A2A, which concertinas down. So if you're short of space, particularly like parental handbags, and not wanting to carry great big volumatics around with them, we quite often use those for little people as well. We've not got a huge amount of time left. So we did have some questions, a little bit about peak flow and about baseline. In terms of that, it's based, from what I'm aware, it's based upon that child's own baseline. You can't just set a baseline. It's normally 80% of their best that they've achieved, and then a worrying sign is if they are at 50% of peak flow. And that's normally a red flag for most of our children. I'm not sure if anyone else uses that. Most of the guidance, somebody was asking about where the guidance is. They couldn't find anything over for a lot of the information that we've been talking about today, especially in regards to devices, more recent than the nice 2001 guidelines, and it is a pain. The BTS sign guidelines are really, really good and really, really clear, as are the GINA guidelines, and they do tend to address a lot more of this than the now quite outdated NICE guidelines. I'm not quite sure why those were never sort of picked up and improved upon. I think the NICE guidelines do touch on it, but not in the same way as the devices guidelines did. Okay, there was a question about MART, weaning and transitioning with it. Are there any possible side effects? Sarah?
Yeah, I think when the SMART regime was first advocated for, it was obviously for adults to begin with, and then it moved down to 12 and above. And in the paediatric area, there was a lot of worry, wasn't there, about all that inhaled steroid and would they have side effects? But I think all of that was cancelled out, and I think that it's been proven to be safe to use that in 12 and above without any side effects. And I think what was the question about transitioning? Would they stay on it? Was that the question?
Yes, so it was weaning off and transitioning with it. I'm not sure what the transitioning was around.
Yes, I'm not sure, but there's no reason why they can't transition still on the SMART regime, if it's still suiting them.
Absolutely. Okay. One for the hospital-based nurses. And for GPs. Have the guidelines changed respirometry and lung function in GPs? As far as I'm aware, a lot of places have restarted spirometry in hospital with some increased PPE. Anyone doing it out in the community that can give us any further updates on what's happening for GPs? Nina?
So you can only do spirometry in children if you are ARTP certified to perform the spirometry. So practice nurses have to do a interpretation and performing course. They have to then do a portfolio, so they can do 10 for adults, and they would have to do 10 for children in order to do this, and they need to do a yearly update. So I'm predicting there will probably be fewer practices that can offer paediatric spirometry. There's
very few courses out there at the moment. Gina, in answer to your question, NICE BTS sign guidelines with Gina. I believe the next guidelines coming out will be a combination of NICE and BTS sign, but not Gina, unless I have heard wrongly. Hopefully that answers that question. And there was one other that I'm going to try and squeeze in before we disappear. Should preventer always be prescribed with reliever? The age-old question. It really depends on the person that has been prescribed it and why they have been prescribed it, I think would be the honest answer. For me, if I see somebody's been into A&E 3 times and they're still only getting salbutamol, that will be me stamping my feet and having a little tantrum, I'll be honest, because somebody's not adding the dots up. If it is a first-time wheezer, then that may be okay and may be appropriate for them. And I think it really does depend on the history that's given with it as to why just that salbutamol was given. For most children, that probably isn't enough. And it needs to be investigated as to why they don't need a preventer and what their clinical history is. That's a very, very brief answer to that question. And the last one that I'm going to touch on is, should practice nurses be listening to chests during an asthma review? I certainly do, if they're face-to-face with me. I like to hear, because for me, not only do I get to hear whether they're wheezy or not, and you can't always tell because they're not always audibly wheezy, but for me, I like to hear how that air entry is coming into the chest. Are they only using the top third? Is this actually a breathing pattern issue alongside asthma? So my answer would be, it's really helpful if you do.
Yeah.
Natasha, I'm seeing nods on the screen.
Also to have, it's also interesting to do a nasal examination alongside that as well. I find it quite useful.
I find quite a lot of nasal polyps at the moment. Always lovely to look at a bit of snot when you're in those consultations. That is the end of our nursing webinar. We have shot through some really complex stuff actually today, and it's been a pleasure to listen to Alison, Natasha and Sarah talk about some of their patients and how they've dealt with things. Hopefully you have all found this useful. For those of you that are in London, we do have a Pan-London nurses meeting that happens quarterly. For those of you that aren't on it, please do let us know in the chat with Georgie and Chris, and we should be able to get you added onto that. You're very welcome to those of you saying thank you very much. Ask About Asthma, we're here all week. We've got blogs, we've got podcasts, we've got recordings of all the wonderful things that you've missed, and there's still another 4 days to go. If you're not signed up to it, please do. They're all on Eventbrite. And if you go on the website, you'll find all the blogs and the podcast as well. Hope everyone has a great rest of their day. Take care. Bye.
Thank you.
Bye.
Thank you.